Hello class, this is Mrs. O'Shaughnessy, and what I want to do for you is just give you some of the information from week 2 that we were not able to discuss in class due to the holiday. So before you is a PowerPoint from your Olson Dimensional Analysis book, Chapter 9, which was one of your required readings. And we're just going to summarize some of the information in that chapter regarding parenteral medications. Okay. We know that a parenteral medication is something that's injected into the body by various routes. This next picture is just showing you an example of ampules. Some are obviously larger than others depending on if it's a medication as shown on the right, or a ampule that has sterile water, which would be like a dilutant to add to a medication. We see ampules as well as vials and pre-filled cartridges or syringes. And as you can see, these are examples of different types of vials. Obviously, some are bigger than others. This is a 30 ml bottle of bacterial static water that may be used for dilution and mixing medications. We don't do that too much anymore. Most of the time, medications that require a diluent, pharmacy mixes those up in little bags for us. We may sometimes have to mix a little powder with medications, but for the most part, pharmacists now do that for us. As you can see on the right, also there's a 10 ml plastic vial of sterile water. On the left is an actual medication. This is what the type of vials that you would administer a certain type of insulin with. So just examples of that, because obviously we're giving some type of parenteral medication. It can be IV, IM, sub-Q, intradermal, those types of examples of parietal medications that we would provide and administer to our patients. This is just a label of a medication, just an example. Again, this is a tuberculin syringe. The capacity for the syringe is 1 ml, and I talked a little bit about this on day 1. It gives you a very precise amount of the medication. Obviously, the medication was ordered as 50 micrograms, and that converts to 0.5 mLs, or a half of an ml. So just showing you that where the actual calibration or mark is where you would administer that medication. Again, another drug label. I'm just going to go through these. These are just examples of drug labels, and this is really important to look at this because this tells you the concentration of the medication. For instance, this one particularly is 50 milligrams per ml. It tells you the route in which you can only administer this medication. It tells you that this is a 5 milliliter multiple dose vial. It tells you that we do not refrigerate or freeze, protect it from light. So those are things that are really important that we need to know, as nurses. So just, always kind of review that label of the medication, because there might be some very important information that you need to know before you administer it to your patient. Again, a 1 ml tuberculin or 1 ml syringe, okay? This is just showing you calibrations of that particular medication that I went over the label with you. It tells you exactly, how much is in an ml, and this patient is to receive a 0.06 mLs, and it just shows you where that would be on this particular syringe. I want you to get comfortable with that. You'll be doing these syringes in lab so that you get the feel of them and kind of understand those calibrations, okay? Again, another drug label. This is a medication, as you can see, that you would give either for IM or IV use. Tells you how many mLs are actually in this particular vial, and just other informations, obviously, how to store it, and things like that. And I just want to tell you, when there's ever any doubt or any questions about a medication, it's always good to refer to our pharmacist, who are the experts with medication. They're the ones to go to, so we can collaborate and make sure that the medication that we're giving our patients is safe for them. Just another label. Again, this is a medication where it would come in powder form, and this label will provide you, as the nurse, directions on reconstitution. Meaning, how do I mix it? What do I mix it with to get the proper dosage that I need to administer to my patient? And these are some examples. Depending on what the order is, this was a problem in your Olson books to do, depending on what you'd have to give. If you're given 250, you would use this diluent. If you're giving 500, and so forth. And if there's any questions about this, please come and see me, because I think this is really important to understand, because depending on that amount of diluent that you put into that vial, we'll give you so many milligrams per milliliter. So, for instance, if the order is, to give your patient 300 milligrams of that particular medication, then obviously you can't use this diluent, because you need at least 300 milligrams, and so you would use this 500. You're not going to give the whole thing, but you'll be able to do a dimensional analysis problem to determine how many mLs you're going to give in order to provide that patient with, for instance, 300 milligrams of that medication. And these are just, how we would reconstitute this medication. This just shows you step by step by step. We're obviously adding sterile water, and it shows you first to obviously inject air into the sterile water, because this is what you're going to withdraw to add to your powdered medication. And then you would withdraw 1.8 milliliters of sterile water, because that's the directions that was on the label, depending on what the dosage of medication is. And then you would inject that sterile water back into the vial, and then you would provide 250 milligrams of ceftriaxone per milliliter, and if the dosage is 250 milligrams, then you would only withdraw 1 ml. So hopefully that makes sense to you. If there's any questions about that, please let me know. Again, labels. Again, another example. You might want to do this. I'm going to upload these PowerPoints to Canvas so that you can go over those before your test on Monday. But here is another example of a medication, Unison, which is an antibiotics, and we're going to give this per IM, and this just shows you how to reconstitute this medication. Again, just labels. This is a Mix-A-Vial, and what this has in it is it's a vial that at the top you can see that it has the liquid, and at the bottom of this vial is the powder. And so what you have to do with this medication is actually depress the plastic cap so the diluent can fall down in this powder, and it falls down in this bottom chamber, in which you're able to mix the diluent with the actual drug. And then, as you can see in step 3, you flip up and remove the protective cover and insert the needle squarely through the center to actually aspirate the medication. And you have to make sure that it's properly mixed and dissolved. One example of this kind of medication is steroids. Your Solu-Cortef, your Solu-Medrol come like this type of Mix-A-Vial. So those are familiar medications that you'll be giving to your patients later on. And as I said, Solu-Cortef, and it just shows you the drug label that this whole 4 milliliters contains 500 milligrams of Solu-Cortef. And you can see here, this is the little cap that you have to remove to obviously aspirate the medication, but you push this down and this diluent will fall down in the bottom of this vial to be able to mix up the powdered medication. And this is just telling you, again, very important to read your labels. Another thing that we always watch is expiration date. Pharmacy is very good about medications that are stocked in our Pyxis, that they have been reviewed by the pharmacists as well as the pharmacist technicians, that they don't put outdated drugs in those Pyxis, but still it's our responsibility as nurses to make sure that something wasn't overlooked, that we're not giving a medication that has been outdated. And these are just many, many types of heparin vials. As you can see, heparin comes in various concentrations. You can get as low as 1,000 units of heparin per 1 ml, as high as 20,000 units per ml. So this is very important to know, because we know heparin is one of those red flag medications that I like to check with another nurse to make sure that I've withdrawn the proper amount, because your patient can have very, very serious problems if we give too much heparin. And the lab values that we monitor when our patients are on heparin, primarily the IV heparin protocol, not the sub-Q that we give prophylactically to prevent our patients from getting DVTs and things like that, is your PTT. And you'll get into that more within your lecture, but just kind of giving you that awareness now of what lab value we monitor if your patient happens to be on IV heparin for some kind of serious problem like pulmonary emboli or acute coronary syndrome. And we don't do this much anymore. I'm just going to pass over this. We do not flush our lines with saline and heparin anymore. We just use a saline flush, and that's pretty much what the protocol is in most of the hospitals. So I'm just going to skip over that. Just another heparin dose. This would be a patient who might be getting sub-Q injection. Usually heparin is given either IV or sub-Q to your patients, and obviously many of our patients who have decreased mobility, who are not moving around as much, when they come into the hospital, they give prophylactic sub-Q heparin just to prevent any potential problems with clots or DVTs. I'm just going to skip over these. Again, a lot of labels that are very important, that you get familiar with these labels and definitely check them. I'm just going to skip over these really quickly, and then talk a little bit about some of the other information that was in Chapter 9 in your Olson book. There's a lot of labels that really may have specific information regarding that medication, and as I said, just pay careful attention to that. What I want to talk about now is just some of the information in Chapter 9. We know what an ampule is. It's that little small glass container that holds a single dose of medication. You have to be very careful when you open that. They kind of like snap open, and there is a picture in your book on 238, and I did show you the slide. The med is aspirated into the syringe by gently pulling back on the plunger. It creates some type of negative pressure. The important thing you want to remember, and I do have this starred, is as we aspirate that, we want to make sure we're using a filtered needle. You might ask why. We're just always worried that when we break that ampule, that maybe little tiny particles of glass have gotten into the medication, and we don't want to pull that into the medication. So we use a filtered needle. So that is a really important nursing intervention to do when you're using medications from an ampule. I showed you what vials look like, glass or plastic containers that kind of has a rubber membrane on the top, and they're covered with lids that maintain sterility. And usually they can either be single dose or multi-dose. And according to the CDC, the guideline states that meds labeled single use are to be used only once. Sometimes these single-use vials may have just a little bit more medications, but you would never save that medication. You would definitely throw that away or discard it according to the hospital policy. Remember, when we're pulling back the medications from a vial, we inject the same amount of air of medication that's to be aspirated from the vial. Okay? You do have problems to calculate. I've answered a couple online that students have sent me questions. If anyone is having any difficulties, please let me know. I'd be glad to help you with that. Remember, as you saw from the PowerPoint slide, that some of the parental medications are supplied in powder forms. And the reason for that is we need to dilute those at the time that we're going to use them for our patients, because they're unstable when they're stored in their liquid forms. So they must be diluted or reconstituted. Usually the two ways in which we reconstitute medications are either using sterile water or normal saline, 0.9%. Those are probably the two most common dilutants. As you saw from the labels, know the order of the drug, obviously, and the different routes may require different strengths. Remember, when we're adding a diluent, there's what we call a displacement factor, so it may have a little bit more increased volume than what actually the volume says. If there are no directions for reconstitution, you can hopefully find some kind of information about that in your PDR, or obviously, as I said before, checking with a pharmacist, or daily medication. I talked about the Mix-A-Vial. You've seen examples of that. Heparin is obviously a very potent anticoagulant. It's a high alert drug. I again want to emphasize that we only give it sub-Q or IV, and it is supplied in units. Okay, we want to definitely assess PTT if our patients are on IV heparin on the protocol. It's very important to know what the antidote is, and the antidote for heparin is protamine sulfate. We would give that to our patients IV and administer that very slowly. I'll be honest with you, in my whole career of nursing, I've never had to give the antidote of protamine sulfate for some problem with heparin. So those are just a little bit of the information from Chapter 9 in your Olson book. As I said, you were assigned certain problems and calculations to do, so you get comfortable with that. If there's any questions with that, please let me know. And now I'm going to just talk a little bit about the prototypes of the classifications of medications that you were required to read about for week 2. The one group of medication that, as you can see up here on the PowerPoint slide, are calcium channel blockers. This is a very, very frequently prescribed drug for our patients who might have problems with hypertension or coronary artery disease. I'm going to download all these little cartoons that kind of help you remember and help you understand what this particular group of drugs do physiologically and why they're prescribed for your patients with those particular problems. All calcium channel blockers will dilate the peripheral arterioles, so it results in a decrease in systemic blood pressure. So that's why patients are prescribed calcium channel blockers, and afterload is reduced. And if you don't understand what afterload is, you're going to learn about that later on. But these are really the very, very important effects that calcium channel blockers have on the cardiovascular system. They dilate the coronary arteries. So that helps bring more blood to the heart muscle or to the myocardium. Your prototype for this type of classification of medications is nifedipine or Procardia XL. And obviously, as I said before, it helps to dilate coronary arteries to help patients when they have stable and chronic angina. And when given as an anti-anginal medication, it can also prevent your patients from developing tachycardia. They use it a lot sometimes for prevention of migraines. So people that have a lot of migraines, it helps dilate the vessels. So that first stage of a migraine attack is when you have vasoconstriction, and that's where those patients or people get headaches from that. How it works is it blocks the calcium channels in the vascular smooth muscle, including the coronary arteries, causing a decrease in the amount of intracellular calcium that's available. So the result for these types of medications are decreased blood pressure, decreased myocardial O2 demand, and as I said before, decreases afterload. It's obviously metabolized through the liver. What are the big adverse reactions? The important thing to know is obviously if it causes peripheral vasodilatation of the arterioles, we're always worried about your patient having their blood pressure drop. So side effects could include dizziness, flushing due to that vasodilatation, peripheral edema, and we really watch out for severe hypotension. That's probably one of the biggest side effects that we can see with our patient. And so if you already have a patient that has a low heart rate, you want to be very careful to be sure to really kind of think about whether or not you want to give a calcium channel blocker. So these are pretty much according to this little cartoon that I have up here on the PowerPoint. Blood pressure is probably the biggest one. Bradycardia may precipitate AV. AV means atrial ventricular block, headache, and those are probably your biggest side effects that we see from calcium channel blockers. So obviously before we give this type of medication, you want to make sure that you're aware of your patient's blood pressure, heart rate, and respiratory rate. Most patients don't have any problems with their liver, but if you've got a patient here that has a history of cirrhosis, you might want to be a little hesitant because obviously that's where the medication is metabolized. Okay, so I really want to just kind of give you an overall view. I don't want to overwhelm you with too much information, but if you know those, that keeps your patient very, very safe. With calcium channel blockers, you might become familiar with the terms negative inotropic effect, which really affects the force of the myocardial contraction, which as you can see causes a decrease in contractility, and that's what that involves. That has to do with your inotropic effect. And then it also has a negative chronotropic effect, which affects heart rate, and it also, to put in plain terms, decreases conductivity of the heart, so that's why it decreases your heart rate. So that's calcium channel blockers, and of course the prototype is nifedipine. All right, so we'll move on. Now we're going to talk about the category of medications called ACE inhibitors, or angiotensin converting enzyme inhibitors. We do see these prescribed for patients with hypertension, so we can classify that therapeutic effect as an antihypertensive medication. These are drugs that affect the renin-angiotensin-aldosterone system, and this is explained in quite detail in Chapter 31 in your Adams Pharmacology book. I'm not going to get into that because it is a complex process that occurs when a patient has a drop in blood pressure. This ROS system is somewhat activated to help increase blood pressure and increase vascular volume. But this medication is widely used for patients that have hypertension, heart failure, and even acute MI. Your prototype for this group of medication is lisinopril or Prinavil. And as you notice with that prototype medication, lisinopril, we always can tell that it is an ACE inhibitor by that that suffix on the end of the word, the PRIL. So that kind of gives you a hint that that's probably a ACE inhibitor, and they kind of work this way. How the mechanism of action works is they bind to and inhibit the action of ACE, which is that angiotensin converting enzyme, thus blocking the conversion of angiotensin 1 to angiotensin 2. And why is that important? Because it then blocks the process of that ROS system continuing, causing a decrease in your serum angiotensin 2, and it reduces aldosterone. And aldosterone in this system is the one that reabsorbs sodium and water, making the vasculature have more volume, thus increasing blood pressure. But think about it. You've got patients who have heart failure. They are already having fluid problems. They're in fluid overload. So we don't want them to reabsorb sodium and water and cause more increase in vascular volume, which puts an increased workload on the heart. So that's what we mean by inhibitors. It blocks that one stage in the raw system to prevent that reabsorption of sodium and water. So ACE inhibitors will result in the loss of sodium and water retention. Okay. Obviously, it's metabolized from the kidneys, so we are always assessing our patient's kidney failure, kidney function. Most common side effect from ACEs are the one thing that it really can be quite obvious is your patient develops a non-productive cough, and you want to kind of watch out for that. But obviously, this medication, since we see it ordered for hypertension, we obviously know that it can affect blood pressure. So one big side effect again is hypotension, orthostatic hypotension, headache. Hyperkalemia is a really important side effect to watch for, so we're always monitoring our patients' electrolytes. And if your patients do have some renal insufficiencies, those are the group, the population of patients that may develop hyperkalemia. The reason you want to be cautious on NSAIDs because people that take a lot of NSAIDs can cause renal insufficiency, and obviously this is a medication that is metabolized through the kidneys. So obviously as nurses, we're assessing blood pressure, heart rate, respiratory rate, looking at BUN and creatinine and potassium levels. If they have problems with their potassium, maybe they have a high potassium, that's concerning to us because the patients can develop cardiac arrhythmias, so we want to be very careful about their diet, assessing diets with a high intake of potassium. So again, just assessing blood pressure, heart rate, looking for signs of orthostatic hypertension. The patient may have dizziness, flushing, signs like that. So that's the most important information that you need to know. This chapter really gets into a lot of details and really explains the renin-angiotensin-aldosterone system very, very well. But I obviously am not going to go into that. But if you do have any questions, please let me know. But it makes sense. You need to know that because that's exactly how these ACE inhibitors work. It's through this system that it inhibits the different steps that hopefully increase vascular volume. But for some of our patients, we don't want that to happen. The next group of medications to talk about are your angiotensin II receptor blockers. And as you can see from this PowerPoint slide, on the left is what I just got done talking about, the PRIL names. And these are various types of ACE inhibitors that may be ordered for your patient. And on the right are your angiotensin II receptor blockers, and those have the sartan names, and your prototype for these are losartan or Cozar, which probably is the most familiar one. We also give a lot of valsartan or Diovan also. And these produce the same effects, but they just work a little bit differently according to the different steps in the renin-angiotensin-aldosterone system. This might be the drug of choice. For instance, if your patient was initially put on an ACE inhibitor and they developed that cough, the patient would be, that medication would be discontinued, and the patient would be put on a angiotensin II receptor blocker such as Cozar or Diovan. Okay, used for hypertension, can also be used for preventative CA with left ventricular hypertrophy. What this one does in regards to how it acts is it blocks angiotensin receptors, resulting in a decrease in blood pressure. It blocks those angiotensin II receptors and prevents a lot of cardiac remodeling and deterioration of renal function in patients with diabetes. It's metabolized in the liver, secreted by the kidneys and feces. Okay. Some of the side effects we see are, again, dizziness. Sometimes we see angioedema with this. Obviously not to use if a person is pregnant. And I think that's really about all. If your patients are on any type of lithium, use cautiously with lithium, may cause toxicity. If your patients are taking a lot of alcohol, it can worsen the hypertension, because obviously drinking a lot of alcohol causes you to, urinate and lose a lot of fluids. So that's why you want to be cautious of that. As nurses, again, checking vital signs, blood pressure, heart rate, a patient's weight. Any patient that is on any kind of medication that affects fluid, hypertension, cardiac patients, all should be on INO. Assessing electrolytes, BNP, BUN, the BUN and creatinine, things like that. So again, watch for lithium toxicity if your patient happens to be on that. So those are what we called angiotensin II receptor blockers. Okay, so that's all I have to say about that. Our next category of meds are loop diuretics, and obviously one of the most common one is furosemide or Lasix. We can also look at the therapeutic classification as an antihypertensive. We use it for, obviously, treatment of acute edema, patients that have heart failure, patients that have renal failure. It helps to remove, large amounts of fluid in the body. Again, this PowerPoint slide that I have on here is just a picture kind of blown up of the microstructures in the kidney, exactly where this medication, this prototype of furosemide, where the action takes place. Prevents the reabsorption of sodium potassium chloride in the loop of Henle, metabolized in the liver. Again, some of the issues that we see with Lasix, it does a good job. Obviously, these patients need to be monitored with their electrolytes, particularly potassium. Many patients that have normal renal failure will be on some kind of potassium supplement because along with the diuretic effect, it kind of pulls out the potassium also. You have to think about fluid being removed in these patients, and so it does affect vascular volume. So this medication will affect a patient's blood pressure, and sometimes patients are put in mild diuretics when they do have hypertension. So it's really important. I don't think we associate blood pressure with diuretics such as furosemide, but it can cause a decrease in blood pressure. So it can definitely cause orthostatic hypotension and syncope. So those are probably the biggest side effects: electrolyte imbalance, orthostatic hypotension. When we give this IV push, in which we do, there's a certain amount of milligrams we should be giving, every minute. This should not be pushed fast, because one of the big side effects from IV Lasix when it's pushed too quickly is ototoxicity, problems with hearing. So that is one thing that you want to think about. If your patients are on IV Lasix, just give it kind of slow, and then of course it really has a very quick effect when it's given IV. So for elderly patients, you want to make sure that they are able to get to the bathroom, because the effect of IV Lasix happens very quickly, and those patients really have to urinate quite a bit. If your patients have a Foley, there's no problem. But obviously strict INO with these patients who are on diuretics, along with weighing them every day. Again, assessing renal function, heart rate, blood pressure, things like that, BUN and creatinine, which is quite obvious that we would definitely assess that with our patients. So, and this is just showing you on this PowerPoint slide where, the loop of Henle is, and where the effects of Lasix takes place. Okay, so I will move on. All right, the next set of medications that we're going to talk about are your beta blockers. Okay, and as you can see, I have the little cartoon up here regarding beta blockers, their action, and definitely those main side effects. Therapeutically, it's classified as an anti-anginal medication, and pharmacologically, it's a beta adrenergic blocker. And as you can see, it ends in OLOL, which kind of tells you that this medication is in this group of medications. The prototype that we're going to talk about is atenolol or tenormin, and this is obviously used for treatment of heart failure, chronic heart failure, hypertension, patients who have stable angina, and sometimes used in post-acute MI. I will say that beta blockers are what changed how people live. It's improved the quality of life for some of our patients who have been chronic heart failure patients. It's almost like a miracle drug. This is an excellent medication which has even put many years of life with someone who has been diagnosed with cardiac problems. So it is just been very valuable for a lot of our patients out there. How it works is blocks those beta adrenergic receptors in the heart, and with patients who have angina. And all angina is patients who have known coronary disease. Maybe they have that plaque or cholesterol building up in their coronary arteries, and they have to kind of live knowing that certain activities will cause them to have chest pain. And so these patients would definitely benefit from beta blockers. It also helps slow heart rate and reduces contractility, which lowers the myocardial oxygen demand. And that's a very, very important action of a beta blocker. It slows the heart rate and reduces contractility, which lowers myocardial O2 demand, because the less O2 demand that's required by the heart, patients will have less bouts of anginal pain. Obviously, since it affects the heart rate and blood pressure, you want to watch for signs of hypotension and bradycardia. Those are things that are probably the biggest two side effects. As you can see here, atenolol is pretty much your second generation of beta blockers. You can see here the three primary actions it has is to decrease heart rate, decrease force of contraction, and decrease the rate of atrial ventricular conduction. So those are the things that I would just tell you to watch. You don't usually stop the medication abruptly. You definitely, again, assess blood pressure, heart rate, dizziness, and look for signs of severe hypotension, signs of heart failure or angioedema, and of course always watch your labs, okay? So very important group of medication, okay? And I'm just giving you the highlights because these are the things you need to know to keep your patients safe. Because think about it, some of our patients with cardiac problems may be on many of these medications. And so if they all affect blood pressure, we're not giving them at the same time. We may be staggering the dosages, but we're still assessing the patient's blood pressure and heart rate, because we want them to go home on these medications, and we want our patients to be safe, because they're not going to probably be checking their heart rate and their blood pressure, even though we should teach them to take, their pulse rate and things like that. But we have to make sure that the dosage we're sending them on is going to be a safe dose for them. And sometimes that's what we have to do when we see the effects it has on these patients. We may have to tweak the dosages because it may make them too hypotensive, or maybe we have to increase the dosage because it really isn't doing much for their blood pressure or for their cardiac status. All right, so that's that. So let's go on to the next group of medications. All right, our next group are cardiac glycosides, or inotropic agents. Your prototype is digoxin or lanoxin. We provide our patients this medication when they have heart failure. This has a positive inotropic effect, increases the strength of the myocardial contraction, but at the same time helps decrease heart rate. It'll help increase cardiac output, which alleviates a lot of the symptoms your patients may have with heart failure. It also is used, for pumping sodium ions out of the myocardial cells. And the thing that you want to assess with these patients is it will affect heart rate, as well as increasing the strength of the cardiac contraction. I remember this drug even when I was in nursing school, because the big nursing intervention was hold the medication if the patient's heart rate is below 60. We still kind of do that now, but we want to make sure that our patients, it's just not a one-time bradycardia that the patient demonstrates. So just be cautious that we're not holding this too long, that maybe it's just only a matter of decreasing the dosage. So let your physician know that maybe the last day or so his heart rate has been down, in the maybe 50s, and you might want to communicate that to your physician. He may change the dosage on it. Usually it's given once a day. This is a medication that is very old and has been around a long time, for many, many hundreds of years. What we also want to be aware of is when our patients are on this, we do what we call a DIG level, because we want to see if it's therapeutic, not normal, but therapeutic. So if you know that your patient's been on DIG for a while, it might be important to do a DIG level, because patients can become toxic with digoxin, and there's a lot of signs and symptoms of DIG toxicity. Always assess that. Maybe look at when their last DIG level was. The antidote for a patient who may have DIG toxicity is Digibind. So just remember that. Again, it really affects more of heart rate than actual blood pressure. Some of the big side effects are obviously bradycardia, and your patients can experience hypotension, but it's really more for bradycardia. Other than that, that's probably the main information that I want you to know. Thing that you really want to watch when your patients are on DIG is the electrolytes, particularly your potassium. Not only for the reason of having potential cardiac arrhythmias, but it can put a patient more at toxicity with DIG toxicity. So those are things that you want to think about. I'm trying to think if there's anything else that I want you to know about. It can affect, the conduction system of the heart. And obviously, if your patient isn't in the hospital and they're not on some kind of cardiac monitoring, you may not be able to see this. That's why it's important that patients really learn how to take their pulse when they're on digoxin. Other than that, some of the signs and symptoms of DIG toxicity, which we need to teach our patient about, are visual disturbances. They might see halos, photophobia, and color perception. So that's very important that we make sure that we teach our patients. We used to use this medication a lot back, 20 years ago when our patients went into a dysarrhythmia called atrial fibrillation, but we use more of calcium channel blockers now. But it will affect the speed of myocardial conduction, decreases sympathetic nervous system activity, and increases parasympathetic activity. So that's about all you need to know, and I hope these little cartoons or little PowerPoint slides help a little bit to learn your medications. Let me bring up digoxin for you. Okay, so you can see that little one. And like I said, I'm gonna download these for you in your modules. But let me bring up digoxin for you. I know it's a lot of medications to learn. I'm trying to just give you the highlights, why your patient would be prescribed these, and really what are those main side effects that we talked about on the first day of class, and some of the other important nursing interventions that we need to kind of think about when our patients are on these medications. I'm waiting for this to load for you. Here again, here's a little cartoon, serum digoxin level I talked about, routes and peaks. We can give digoxin orally or IV. Obviously, as I said before, it's very important to monitor potassium levels, which we do anyways. And it says before you add digoxin that heart needs to run at least 60 beats per minute. So that's what I was talking about, because it really does affect heart rate more than blood pressure. So you do want to assess that heart rate, okay? So that is your little cartoon on digoxin. So let's move on to the next group of medications. I don't have a slide on the next group of medications, your potassium-sparing diuretics, aldosterone antagonists, also in the classification therapeutically for antihypertensives. Your prototype for this is spironolactone or aldactone. We see our patients prescribed with this medication when they have mild hypertension. Pretty much the side effects that we would see with this would be some hyperkalemia, because obviously it's a potassium-sparing medication. We also see sometimes within men they can become impotent, gynecomastia, and diminished libido. Women may have some menstrual irregularities, hirsutism, breast tenderness, and some of these blood dyscrasias, meaning that they have low white blood counts, which really puts them at risk for infection. How it works is it inhibits aldosterone in the distal tubules and collecting ducts of the nephron, and when aldosterone is blocked, sodium chloride, water excretions are increased, and then the body retains potassium. So that's how the mechanism of action is. Obviously, blood pressure, heart rate, that's just always a gimme with some of these medications. Watch for swelling, intake and output. Because it does increase water secretions, being that it's a potassium-sparing diuretic, just watch for signs and symptoms of dehydration and hypotension, and monitor also for hypovolemia and things like that. So those things that you might look for an overdose is drowsiness, mental confusion, and that would make sense because the patient would be extremely dehydrated and have obviously signs and symptoms of hyperkalemia. So that's that medication. Your next one is I think it's, oh yes, it's your anti-anginal, your nitrates, okay? And your prototype for this is isosorbide or Imdor. And what we see with this medication, it's used for to prevent chest pain, angina. And how this medication works is it dilates the blood vessels, making it easier for the heart to pump. It really works more on the veins than the arteries unless we give a higher dosage. So again, we've got a patient that we're definitely watching their blood pressure. Okay. Sometimes when these patients first get on these medications, the nitrate group of medications, they might really have a really bad headache because it dilates not only the veins in the coronary and in the heart, but also in the head, in the brain. So sometimes these patients have to get a little bit more adaptive to the medication. So just treat it with Tylenol and just kind of watch the patient to make sure that it doesn't get any worse. These medications can be given orally. The nitrates can also be given as a nitro paste, which is put on the skin. It kind of is absorbed slowly. And then it can also be given IV. So those are some of the routes in which we would give some of these nitrates. But your prototype for now is your isosorbide. That's about it on that. So I won't say any more. So the big thing is obviously hypotension. Okay. The next one that we're going to talk about is since perfusion, cognition, think about your patients who might have a stroke. We're going to look at some of the non-hemorrhagic anticoagulants, and one of them is heparin, and I've got the little cartoon up there for you. I talked a little bit about heparin. It's an anticoagulant. It's an indirect thrombin inhibitor used to treat DVTs, PE, and PMI, unstable angina, prevent thrombosis in high-risk patients. All right, now I've talked a little bit about heparin. Another thing you want to watch with heparin is a patient's platelets, because heparin can produce or cause a problem of what we call HIT, or heparin-induced thrombocytopenia, which involves the number of platelets a person has, and we know those cells are responsible for clotting, so we usually hold heparin if the platelets are below 100,000. And again, we're watching a patient's urine, stool for signs of bleeding, oral mucosa, things like that, because that could cause your patients to start bleeding. So even things like arterial sticks, if your patients need blood gases, if you start an IV, remember it's going to affect their patient's PTT. That is the lab value that we monitor when they're on IV heparin. Again, I've already told you what the antidote is, just be aware of that, okay? Okay, the last medication that we're going to talk about is your dexamethasone, or Decadron. It's an anti-inflammatory, immunosuppressant, and the pharmacological classification is a glucocorticoid. And I've got a little cartoon up for this. These are obviously examples of corticosteroids, and we're more concerned with the prototype of dexamethasone, which is Decadron. Okay, routes can either be IV push or PO. How this medication works: it treats inflammation. It works by decreasing or preventing tissues from responding to inflammation. It also modifies the body's response to certain immune stimulation. And really, some of the side effects that we see with this is difficulty sleeping, feeling of a whirling motion, increased sweating. That's probably the most common side effects that you would see with this medication. This is an old drug. I'm not sure how much of it we use anymore. We use more of the methylprednisolone and the prednisone, the deltasone. Steroids can be good, but they can be bad, and they can also be ugly. You want to be careful if they've been on them for a long time, that we don't want to stop them quickly, because normally cortisol, which is a steroid, comes from your adrenal glands, and when you take exogenous or outside types of corticosteroids, your body stops producing them and stops secreting them, because you're getting outside sources. So if you stop them abruptly, your body doesn't have time to recover. So you could go in what we call an adrenal crisis. So that's why it's very important that a person not stop these. And if you've ever been on steroids, maybe due to a respiratory infection, you'll see that the package of medication has a decreasing dosage. You start at a high dose and then you just start tapering off, okay? Obviously, looking at your patients, medical history, assessing vital signs, which we do anyways. We used to give this a lot for our head injuries to prevent cerebral edema. So I would think that we look at a patient's changes in level of consciousness and really report any signs of headache. Okay, so that's basically your prototype, your medications. I hope this helps a little bit to kind of see some of the big picture of the medications, get a general overall of what exactly each of them does and why we give them, and just picking out those really major side effects with the medications. If you have any questions, please let me know. I'm going to post this sometime today, which is Wednesday, and so you'll have this to kind of review and listen to before your test. If you have any questions on the information before the test on Monday, please feel free to either text me or to send me an email through Canvas. And I hope you have a great day.